Next up is Dr. Deepak Agarwal. He will actually be speaking on behalf of Dr. Abhishek Bose, who could not make it due to some emergency at home. And he will be speaking on CNVM with macular hole. So welcome Dr. Deepak, who is a prolific surgeon based in...
So I'll be speaking on behalf of Dr. Abhishek. I'll take this opportunity to present my video on double trouble of fluid and flap. So no financial disclosures pertaining to this particular talk.
Double trouble of fluid and flap. A 65-year-old lady presented with dimness of vision in both eyes. Best corrected visual acuity was 2/60 in right eye and 6/36 in the left eye. Fundus of right eye shows pigmented lesion at macula, while left eye shows whitish macular lesion with exudates. OCT right eye shows scarred CNVM. Left eye shows CNVM with cystoid edema and subretinal fluid. Left eye intravitreal anti-VEGF injections were started. But after the third injection, there was resolution of VMT with formation of a large full thickness macular hole. Challenges in the present case are a one-eyed patient, already diseased eye, difficult intraoperative identification of macular hole, and ILM peeling to be done over CNVM. After detailed discussion with the patient, surgery was planned. Vitreous stained by triamcinolone. Posterior vitreous detachment induction was done. Vitrectomy completed. Brilliant blue dye injected. Internal limiting membrane peeling was initiated. The plan is to do an inverted ILM flap. Things were going really well when this happened. The ILM flap got dislodged from the hole margin. Now PFCL was injected. ILM free flap was made. Using silicone tip, this free flap was positioned in the macular hole gently. PFCL was removed. Fluid air exchange performed. Postoperative OCT showed closed macular hole with BCVA of 6/36. The learning points in this case are: Intravitreal injections can cause resolution of VMT. The VMT resolution may lead to a macular hole formation. ILM peeling is a viable option for macular holes in CNVM. Keep calm and carry on after an intraocular complication. Free ILM flap can be tried in dislodged ILM cases. Thank you.
Thank you, Dr. Deepak. Very nicely shown, surgery. And just one thing here is, what happened after? Did the CNVM come back? And how long follow-up you have?
Very fortunately, for last 3 months, there has been no collection of fluid. Interretinal fluid is not there. Very small pocket of SRF is there. But as per the guidelines, the recent guidelines from the European Society also, we are tolerating some amount of SRF. We are not injecting for very small amount of SRFs.
Right. So one has to, carrying on from your mention about SRF. If the SRF is coming back and if it's increasing, then obviously you need to re-inject. But having said that, in a lot of situations where you've done a surgery, VR surgery for some other reason, which had a CNVM or developed a CNVM subsequently, when a subsequent CNVM develops, then there is no doubt about injecting anti-VEGFs. But if it's a patient with a CNVM that has developed something like this and a surgery has been done, or retinal detachment has occurred and a surgery has been done, what one sees is God gives us a time of maybe 2 to 3 months time wherein the CNVM doesn't come back. So and then one has to be very careful. You have to do your OCTs every month, and the moment you feel that it's reappearing, it's recurring, then obviously you have to re-inject anti-VEGFs. So any other questions from the audience?
I have one question. Deepak, great presentation, obviously. One thing, when you are putting that ILM flap in the hole, so if you are using soft tip, obviously it may little bit damage that underlying RPE.
Yeah.
So what on that? Can you use forceps in that?
Forceps to do what?
To place that ILM flap.
Forceps can be tried, but since as also shown by Dr. Soman Mandal sir, at times what happens is when you are using a PFCL, so these flaps, this retinal flap or an ILM flap might float onto the PFCL. So that becomes extremely difficult to reposition it again. So what I have done in this case, and I will, if needed, I'll do it again if in such cases. So what I do is that after generating this flap, I only drag it very gently. It has to be very gentle, of course. Very gently, it has to be dragged below the PFCL to the holes. If you are using a forceps, first of thing, below the PFCL, you are not able to use that very much, and there is always a chance of injuring the retina, underlying retina. So rather than using a forceps, I will personally like to use a soft tip. But yes, the opinions can differ. I feel much safer with the soft tip.
I think the point you have raised is very pertinent, and I would like to agree with Dr. Deepak that it's better to use a soft tip here. But with a flute needle, if it's a soft tip with a flute needle, tagged onto a flute needle, often it can happen that the flap can enter the flute needle. So the one way you can do away with this problem is load your soft tip needle onto a 1cc syringe with a stopper, that is with a plunger that is fully closed, and so then you will not have any ingress of the flap into the soft tip cannula. So that is something that can save the day for you.
One more tip to do so also is that you can keep the vacuum very low, and other thing is that in a flute needle there is an opening. There is an opening from which we do fluid gauge assay. So you can close that opening with your thumb.
Absolutely. Yeah,
that will in majority of the cases it will prevent this egress of the flap through these holes. If you have closed it, there is no pressure difference. So if there is no pressure difference, the flap will not enter the tip.
Absolutely. Yeah, sure. Yes, Neha, please.
If we can use a diamond dusted forceps which is old.
To be very frank, I have no experience with diamond dusted. So if you are comfortable with that, that's okay. But I have no experience with diamond dust. I have never used it.
There are publications using old diamond dusted Thanos, like, you know. Yeah, yeah, yeah. You can use that, but there shouldn't be any diamonds there. Uh,